I'm going to talk about pathophysiology of frostbite, and depending on how we're going on time, we'll talk about other cold injuries. I'm going to start with a thanks at the beginning. I've worked with a lot of people over the years and been very grateful for all the support and interactions we've had, and I listen there. But one in particular is the late Emmanuel Cauchy, who's a physician in France, and we'll talk about quite a lot of the contributions he's made already to frostbite, and you'll see why he's so important. So I'm going to start with a case study, then we're going to talk a little bit about cold, then we'll talk about peripheral cold injuries, starting with frostbite. We'll have a look at the time and see where we are as to whether we can go on, and then we'll come to some conclusions. So I'm going to start with a case history, and this is a video that was in fact sent to me by a patient of mine. He is a 39-year-old. He had a long summit day on Everest in 2016. He had equipment issues. By that I mean he left his mitts, he thought in his tent, but sadly in fact they were in his rucksack. This is the summit of Everest, 2016. So quite a lot of the work we get comes from extreme environments, quite often from Everest. There are a lot of people attempting to climb it these days, and it doesn't go quite as well as planned. These particular people had quite a lot of training before they went, but ran into trouble. So this particular team was struggling quite badly. They had other people with high altitude cerebral edema. They managed to evacuate them by helicopter from Camp 2, which isn't typical, and got them to base camp. And we're going to talk a little bit about this in terms of treatment. Rewarming is a key feature. You can see the poor climber involved being rewarmed. Supplementary oxygen. He's talking to his team. And you just get a glimpse of his hands there, which don't look too bad. So what she's explaining is there's some drug treatments that could be suitable to be used, and we'll talk about those in a moment. So what causes frostbite? The pathophysiology. Heat losses, you're all very familiar with this. 4 different sorts of heat loss: convection, evaporation, radiation, and conduction. And environmental heat losses will come across for a number of different reasons. The absolute temperature is clearly key, but we're very familiar also with wind chill. Whether you're wet or dry is important. Altitude, which you're beginning to realise is a risk as well. Equipment, it's not just whether you've got good equipment, it's whether you're using it, and that's what we saw in this particular individual. Nutrition, hydration, duration of exposure, and the individual's response. This was a slide that came from Mike Tipton, the hierarchy of survival. Lack of oxygen is what kills you first in a couple of minutes. So that could be circulatory or respiratory. Thermal imbalance and hypothermia is another major problem. But fluid and energy takes quite a lot longer to cause problems. There are certain risk factors that increase the risk of frostbite. So some of them are behavioural, and we've seen some of that already today. Some of them are physiological. Different individuals have got greater risks. Certain conditions like Raynaud's phenomenon seem to increase it. Previous frostbite is an issue. And then some of them are mechanical. If we look at altitude, this is a study that was published by Dan Martin. What he was doing was using video cameras to look underneath the tongue to look at the circulation. And you can see here at sea level, there's a very brisk movement of the red cells. But at altitude, with a much higher hematocrit, the blood is sludging quite badly and moves very slowly to under the tongue. And this is likely to be occurring in the periphery. Another study published a little while ago looking at cold-induced vasodilation, both at sea level and at altitude, shows an attenuation of that response at altitude. So the dotted line underneath shows the effect of being at altitude. So first of all, the response comes on slower and it's much more diminished than it was at sea level. And then this was a study that our medical students did in Birmingham. What they did was they went into a hypoxic chamber and using a 200-pound portable FLIR camera that goes on a phone, they were able to take pictures of hands. The room temperature in that hypoxic chamber remained constant at 18 degrees centigrade, but you can see how the periphery, the fingers are getting cooler at the simulated high altitude. And then on returning to sea level, when they turn the dials back to an FiO2 of 21%, they return to normal. So again, another aspect that may occur at altitude. So the pathology of frostbite it's a vascular injury. So you see extracellular water crystallization causing changes in osmotic outflow. This leads to intracellular dehydration and damage to the capillary wall, endothelium and cell death. This is associated with the release of inflammatory mediators, reduction in plasma volume, reduced blood flow, capillary sludging and platelet aggregation, and then eventually cell death. So this is a cartoon which just shows the platelets aggregating and gradually filling the periphery. And this is a slightly more detailed account of the same thing, where the stabilization of these clots, the sludging that is occurring in the periphery, is taking place. So clinically what happens, they present with a woody sort of feel to the extremities, and then they start to see edema formation after about 4 or so hours, and that continues for another 5 days. And then after a period of time, you'll see tissue loss, gangrene forming in as the cells die off. And you can see the sludging that takes place. This is electron microscopy of the platelets aggregating. So what's going on? Normally there's a satisfactory supply of oxygen that allows ATP and ATP to be in balance. But as there's an oxygen lack, then what you see is that mismatch until gradually you see the cells beginning to fail, and eventually you will end up with cell necrosis and death. So let's just think about the conventional management. This is a South Korean climber who came off Everest in not a dissimilar position to the one we've just seen, and this is her hand about 3 months later, where the cells have died. You've got auto-amputation taking place, and clearly in a young woman, that's a life-changing event and very serious. So the 2 questions that we need to ask at presentation are, first of all, is it mild or severe? Because if it's not severe, we don't want to risk anything further, and I'm about to talk about that in a moment. And did it occur within the last 24 hours or so? Because if you can't get in to try to clear those clots at an early stage, it's not likely to work. So again, time of presentation is key. This is all outlined in a review article that we published a couple of years ago. It's open access, so this can be obtained. The key thing is to treat the hypothermia first. That's in the first red box. The patient will die from the hypothermia. They're not going to die from their extremities immediately. Once you've warmed them up satisfactorily, then you can start to set about how you deal with the extremities. So the first important question that a lot of the climbers want to know is how severe is the injury and what's likely to happen, or will I lose my fingers? And this is the first really important piece of work that Mani Kaushi came up with. Up until this point in time, what we usually did was just sit and wait until there was demarcation. But by coming up with a system of using technetium to assess how severe the injury was, you can look at technetium perfusion into the extremities to predict what's likely to happen. So on day 1 or 2, you can always already work out what's likely to happen 2 or 3 months down the line. So this patient, what's going to happen? We look at the technetium scan. You can see there's no perfusion to the tips of the extremities. One could predict there's going to be a poor outcome, and sure enough, it's not quite as bad as predicted on the technetium, but it's not great. And then the next question I said is, how recent is it? So these clots that have formed, the sludging of the periphery, there's now evidence that you can clear those quite quickly. If you think about the treatment of heart attacks, and strokes, if you can get in there within a couple of hours or so, you can get a much better outcome. We think the metabolic rate of the extremities is probably not quite as high, and so you might have up to 24 hours or so, but that's not hard data. So this is one of the first studies published on thrombolysis, and what they were able to show was a better outcome in those patients who were predicted to do badly, who had early thrombolysis. What you're doing is injecting a drug into the artery and clearing the clots. So you can see over on this side here, there's very little perfusion to the tips of the toes, but after 24 hours of thrombolysis, there is a significant improvement. So we end up with this overall view of how we should manage these patients, which was published in the BMJ a little while ago. So the next big event that came out was the use of these vasodilators and the thrombolysis. And this again is Manny Cauchy's work. Iloprost is a synthetic prostacyclin analog, which is a powerful vasodilator. At that time he did this study, bluflomidil, which is an alpha blocker, was reckoned to be the best treatment. And what he did was took patients that came off Mont Blanc in the helicopter with frostbite, and he didn't look at the most minor forms of frostbite, but 2, 3, and 4, the more serious ones, he would randomize them to one of 3 treatments, either iloprost or bluflomidil, the conventional treatment, or a combination of the TPA and the iloprost. And here, this is one of his slides in French. You can see that stage 2 didn't really make too much of a difference. But in terms of amputation rate, the risk of amputation, which you can see on the y-axis, the bluflomidil really doesn't work very well, whereas the prostacyclin and TPA combination dramatically reduce the risk of that subsequent amputation. So a remarkable step forward. So how do we get to see these patients more quickly? We've been running a UK telemedicine service now for the last 10 years or so, and what we are able to do is offer advice at an early stage as to how to manage these individuals. And this, if you want to go to the internet, you can find that from the BMC. This is run through there. So let's go back to this case study. We've got this guy. He was actually transferred back to the UK approximately 20 days afterwards. His hands are not looking good. He's already had iloprost, but it was given rather late and so subsequently didn't work. And we've got this guy, the technetium scan shows that he's not going to do well. This is his hands, and the sort of level of amputation that we're looking at are likely to be life-changing. So we took him to theatre. You can see the approach. What you can also see on the tips of the fingers or the digits that are left is the rather blackened bone. That's dead bone. So what we've done is strip back the tissue but not take away the dead bone. Normally we'd take it back quite a bit further in order to get a decent closure, but in this particular case we had read, and this is the sort of level we'd amputate, we'd read about someone who had a lightning strike, and this was the thumb. So this is not frostbite, this is a lightning strike. You've got the same dead bone. And what they did is use a technique that was used in the Second World War, the First World War for the first time, which was burying the digits into the abdomen to revascularize it. And you can see the successfully revascularized digit there. So we did the same thing. We popped this guy's hands into his belly for a period of a month. And we'll move quickly on. I can see a little nervousness here. We decided only to put one hand in because the other hand, we felt it was really pretty tough to tie him up like this, really. And so in order to communicate, because English wasn't his, didn't speak English at all, actually, he had to use a phone. So anyway, end result, we managed to save quite a bit of his digits, and he was able to clean himself, eat and drink, tie his shoelaces, and in fact sent this video, this is the second half of the video, a couple of months, well, a year later. So this is the end result. I'm not going to go through that bit, but he set off to climb the Matterhorn. So this is his own video that he took, and here he is in the mountains again. I'm not going to go through that in great detail, But I think what you can see is this is a continuous form of treatment. There are a whole series of little steps. There's not a lot of evidence for this. You can't go simulating these sorts of injuries. So a lot of it has been discovered over a period of time. Some of it's possible in animal models, but some of it isn't. So a summary, interim summary, we've got frostbite. Prevent it if you can, don't get it. If you do get it, rewarm it quickly. Seek advice from a specialist unit. Consider thrombolysis if it's a serious injury and it's presenting early on. And delay surgery unless there's overwhelming evidence of sepsis or compartment syndrome. And people who have had a cold injury are more likely to have to be susceptible to a further injury. Now, based upon my clock, I've got another 10 minutes or so to go. So, yep, all that information can be found at the Wilderness Medicine Guidelines. That's just, I think it's just been published. It's an open access thing. So do go to that if you want further information. So 10 minutes on non-freezing cold and then some time to talk. So non-freezing cold, this is by definition not a freezing cold injury. So this is all the time that people spend in cold, wet conditions. This is a much more common problem to see in the UK than in these extreme environments. There's no tissue freezing. The long-term sequelae are serious though, with cold sensitivity, hyperhidrosis and pain. It seems to be a combination of both a neuropathy and a vascular injury, and it's endothelial mediated. And we'll go through this in a little bit more detail. So this is a case report that John Castellani, who we write the chapter for the Auerbach textbook. It's really nice to meet John. We've written this chapter a couple of times now, but we've never met. This is the first time we've met, so it's really nice to meet John. So this is a patient of mine. He's had psychiatric problems, spent some time in the woods between April and June outside Coventry. At no point did the temperature go below freezing. My colleagues saw him, took off a couple of gangrenous toes and thought that was the end of the problem. But he then began to develop an osteomyelitic sinus that discharged, and he ended up having a 4-foot amputation. So this you can begin to see as quite a serious injury. In fact, in some ways more serious than the frostbite injuries because of the ongoing neuropathy and problems he had, the insensate foot that behaves like a diabetic foot in many ways. There's a long history of this. We go back to the BMJ in, it says 2016, it's actually 1916. This is the First World War that this case report was put into the BMJ. And they described, on putting on their boots again, these men were unable to walk. And so they were beginning to show demonstrate problems at a very early stage. Again, this is very much a military condition, and we're at the centre in the UK, where or very close to the centre, at the Institute of Naval Medicine in Gosport. And Ungley published this paper in 1942 in the Lancet, describing the different phases that certainly suggest there's a vasospastic component to this. And you go through these different phases, and I won't go through them in detail because of the time we've got, but you can easily find that out. There seem to be certain sorts of predispositions to this problem, and in particular, the Afro-Caribbeans seem to be at much greater risk. So again, this is a study that was published a couple of years ago, looking at the risk of developing non-freezing cold in different ethnic groups. And there is a 30-fold increase, roughly, in the Afro-Caribbeans of developing this, which is clearly very significant, particularly if you're going to recruit a lot of troops from these countries. We talked briefly about the hunting response or cold-induced vasodilation, and this was a study by Matthew Bailey, Claire Eglin, James House and Mike Tipton, looking at the differences in this hunting response effectively between the different ethnic groups. And you can see the Caucasians there seem to have the best response, and the Afro-Caribbeans have the least good response, I suppose is the best way of putting it. And so probably the Afro-Caribbeans are likely to be more susceptible to this. It's not just a military thing. This is someone who's been bailing for 18 hours in Alaska in seawater, and you can see at an early stage we've now got the hyperemic phase, the swollen digits. And this is something that, is Nuala in the audience? Yeah. Hi Nuala. You put it in a public forum, so I'm hoping you don't mind me putting it in a talk. Nuala posted this only on the 29th of this month. Nuala, you'll have a great opportunity to talk to her. She's a very, very enthusiastic cold water swimmer and has done some amazing swims in around Cape Horn.
Yeah, yes.
So, and one of her problems is what I think is probably a non-freezing cold injury, but you can see the state of her hands. It must be unbelievably painful swimming with, or even just doing up your shoelaces or whatever, with hands like that. I hope you don't mind me doing that. As I say, I've got another photograph, which is not you. This is, I'm not going to say who this is. Came in the same day. This is someone who spent some time in the Arctic in cold, wet conditions. I'm aware of time of, no, the buzzer, it hasn't gone yet. So what are the potential mechanisms in non-freezing cold here? We seem to start with cold, wet exposure at the top. This seems to cause vasoconstriction and reduced blood flow and might lead to ischemia. But it also might, if you come across to this side here, see nerve cooling and possibly nerve damage as a result of this, particularly if you get that sludging that we saw in the frostbite injury. If that was to occur around the nerves, you might end up with permanent nerve injuries and then end up with a sensory impairment. And also, as a result, downstream, you may end up with a cold sensitization. This is an animal model for a non-freezing cold injury. What they did was took a rat, and in the top one, those are the controls. In the experimental model, what they were doing was cooling the tail of the rat. And you can see the blood flow, which is the blue line there, in minutes during the cold exposure. This is the blood flow within the blood supply to the sciatic, to the nerve of on the tail. And you can see how it drops. It reaches a minimum somewhere around 200 minutes or so. But it then takes, you can see at the second part of the graph, it goes up to day 5. You can see a very slow return and it never gets back to normal. So you could imagine those vessels sludging up and then you now have an ischemic injury, a bit like a mini stroke, but this is on a peripheral nerve. And this is some of the photography that they took during it, the microscopy. And you can see how it's shutting down as one moves from A through to E. And then as it warms up, it remains sludged off and still not working. An animal model, not perfect, but at least it gives us some insights into this. The diagnosis is really problematical with these patients, and there's a huge medical legal litigation issue around here. But it's fundamentally based upon a history and an examination, and then a series of investigations. And over the years, a number of different ones have been used. Infrared thermography was popular. Thermosensory thresholds, again, have been used. And most recently, there's been a paper that's come out of the Oxford group showing a sensory neuropathy. They've done intraepidermal nerve fibre biopsies and shown small fibre degradation. And as a consequence, we're beginning to learn where the future might be in terms of making a diagnosis, but we still don't have adequate controls. Treatment. Sarah Gillespie in the military has done an awful lot of work over the last 5 or 10 years trying to change the way we do this. Again, prevention is the most important thing. Trying to treat it is difficult. Early recognition, taking the patient out of the cold, wet conditions, warming them up, using air warming rather than water, treat their pain aggressively and early, and avoid future exposures. So pulling the two talks together, peripheral cold injuries are not uncommon. The injury type has different features depending on the time of exposure and the temperatures encountered. It can have serious and life-changing consequences, and we've seen amputations, significant amputations in both frostbite and in non-freezing cold injury. And there's an evolving understanding of the pathophysiology, but we're a long way from it. As I've indicated, it's quite a difficult area to investigate because of the nature of it, and animal models are not perfect. But prevention is better than treatment, and I'll leave it there. Thank you very much indeed.